to help us today in Seattle-King County, as he has helped us nationally with AIDS programs. Greg Millett is here, and Greg has a long resume. I won't review it all, but he's coordinated the National White House Office of National AIDS Policy. He's co-authored President Obama's National HIV AIDS Strategy. He helped organize the International AIDS Society Conference in Washington, D.C., which was a huge success this year. He helped to eliminate the U.S. travel ban on HIV-positive persons. He's a particular expert in HIV-related disparities among minority populations and among MSM. So, Greg, we're honored to have you here and looking forward to a lot of help from you as we continue to work in innovative ways for our own programs. So let's welcome Greg Millett.
Thank you, Dr. Holmes. Good morning. It's really a pleasure to be back in Seattle. After spending the last 15 years at the federal level working on HIV AIDS, it's rare that you come into a community where you have really the trifecta that Seattle has. And the trifecta being, a huge research base in terms of fantastic researchers at the university level. You have an effective health department that is really doing some fantastic work that's based upon that research. And then you also have an engaged and informed community that is really doing incredible work at the CBO level and elsewhere. And, when you take a look across the United States, I can tell you that you usually don't have all three at the level that you do here in King County. So you're really just an incredibly special place, and it's just a great opportunity to be here this morning. As Dr. Holmes mentioned, I wanted to speak today about reducing HIV transmission among the U.S. and some of the opportunities as well as challenges that we're seeing in terms of HIV prevention as we move forward with trying to get to zero new infections. And with that, I'm just going to start really briefly with a brief epidemiological background of HIV in the United States. And a lot of these data are data that many of you in the room are already familiar with. You know from CDC data that there are about 50,000 new infections that take place each year in the United States. And when you take a look at the demographics of those infections, you find that not everybody is at equal risk for HIV in the United States. And it's been like this for quite some time. We know that in terms of new infections in the US, it's primarily men who become infected with HIV each year. By race and ethnicity, it's primarily people of color, African Americans as well as Latinos, who become infected with HIV each year. Though in terms of our incidence estimates, we also have 2% incidence among Asian Americans and about 1% incidence among American Indians and Alaska Natives. And then by transmission categories, it's primarily a disease that affects gay and bisexual men, representing about 2% of the population, greater than 60% of new infections that take place each year. And when you take a look across all racial and ethnic categories, you find that men who have sex with men comprise the majority of cases. For Black MSM, Latino communities, Asian Pacific Islander communities, Alaska Native communities, MSM are really the one group where HIV incidence as well as HIV prevalence is greatest. And really just to bring some of that home in terms of what we're seeing in terms of the demographics of HIV in the United States, these are data that a colleague of mine from CDC published a couple of years ago, looking at the lifetime risk of HIV diagnosis by race. And you see some things that are really startling here, that among whites, that white men have a 1 in 104 chance of becoming infected with HIV in their lifetime. White women, about 1 in 588 become infected with HIV in their lifetime. And then you see for Latinos as well as African Americans that the likelihood of infection really is dire. With Latinos, about 1 in 35 men have a likelihood of becoming infected in their lifetime. Latinas, 1 in 114 have a likelihood of becoming infected with HIV. And then among blacks, black men, 1 in 16 in their lifetime, and black women, 1 in 30 in their lifetime. And when you transpose this with men who have sex with men, unfortunately the numbers are even worse. So among whites, and when you take a look at some of the studies that we've done looking at behavioral surveys in 21 US cities, we found that 1 in 6 white MSM were HIV positive. For Latino MSM, 1 in 5 were HIV positive. And for black MSM, 1 in 3 were HIV positive. So the epidemic among men who have sex with men in the United States really is akin to some of the generalized epidemics that we see in sub-Saharan Africa and other places where as many as 1 in 5, 1 in 3, 1 in 2 individuals are infected with HIV. And unfortunately, when you take a look at the number of new infections by age, we find that youth are at highest risk for HIV in the United States, and particularly young MSM. Youth comprise about 26% of new infections nationally, and unfortunately, 4 or 5 of those infections were among males, just like the larger epidemic. 70% of new infections among youth are among men who have sex with men, and young MSM are the only population in the United States where new infections have been increasing over the past 3 to 4 years. With an astounding 48% increase among young black MSM between 2006 and 2009. So what are some of the reasons why we're seeing some of these higher rates of HIV taking place among men who have sex with men in the United States? You know, from the very beginning of the epidemic, everybody would take a look at risk behavior and think that, well, perhaps risk behavior might be the reason why we're seeing such high rates among men who have sex with men. But risk behavior does not necessarily explain why we're seeing such high rates among men who have sex with men compared to other populations in the US. And these are actually data that were just published, I think, last week from the National Survey of Family Growth. It's a multi-stage national probability sample of individuals between the ages of 15 and 44, and they have some really interesting results looking at men who have sex with men between 2002 and then 2006 and 2010. And what you could see among all men who have sex with men, that the number of male sex partners between those time periods actually decreased between 2002 and then 2006 and 2010. And there was also a similar decrease among young MSM. This is the group where new infections are increasing. There was a decrease in the number of new partners between that period of time. Condom use was the same across the time periods. Injection drug use or sex with an IDU partner actually decreased in the time period, whereas STD testing as well as HIV testing was pretty much comparable. Yet we're still seeing an increasing HIV infection as well as STIs among men who have sex with men. So risk behaviors are not necessarily explaining why we're seeing greater risk among men who have sex with men. And there's other data that support this as well, and in many ways we have to redefine what we mean by risk. For instance, just last year, CDC published data from NHBS, some of our surveillance data, where for the first time in CDC history, those MSM who had a new diagnosis did not engage in greater rates of risk behavior. So you found comparable new diagnoses among MSM who reported that they engaged in recent risk behavior, and those MSM who said that they didn't engage in any recent risk behavior. We also know, too, from some terrific work that Patrick Sullivan and others have done at CDC, that about 68% of HIV transmissions take place in the context of a main partnership. So these aren't men who have sex with men who are going out and getting infected through casual partners. These are partnerships that are taking place while within the context of a main relationship. And that's not necessarily what we would traditionally call high risk. And even some fantastic work that Stephen Gaudreau had done several years ago that I was happy to see got picked up and amplified in the Lancet special issue last year. Even if you look at US MSM compared to heterosexuals, and we had the similar number of sex partners, we would still unfortunately have an epidemic among men who have sex with men. And part of the reason why we'd still have an epidemic among men who have sex with men is that there's a greater likelihood of HIV infection for anal sex as compared to vaginal sex, an 18 times greater likelihood. We also have role versatility among men who have sex with men, which really amplifies the infection compared with heterosexuals. So a heterosexual man, of course, is more likely to transmit to a woman, but she's less likely to transmit to her male partner in the United States. Whereas among men who have sex with men, people can be the top in one relationship and then act as a bottom in another relationship, and it amplifies HIV throughout the population. And Stephen just also did some fantastic work where we looked at the anal sex and vaginal sex probabilities over a 5-year period to see if there's any differences in HIV incidence if you set them the same. And you actually find that there's an 80% reduction in HIV incidence over 5 years just by setting anal sex equal to vaginal sex transmission probabilities among men who have sex with men. And if you restrict the roles of versatility among men who have sex with men, you find that there's a 40% reduction in HIV incidence over 5 years. So risk behavior is not necessarily explaining why we see such greater rates of HIV infection among men who have sex with men. Now I want to talk about a lot of this in the context of biological interventions to reduce HIV transmission among men who have sex with men. Over the past several years, there have really been a revolution in terms of biological interventions to reduce HIV transmission in the United States. And this is a rundown of many of the things that have taken place in terms of efficacy, which of course, treatment is prevention being number one, PrEP, several PrEP studies that have come out, microbicide, the first effective microbicide for women in South Africa, and then of course the first effective HIV vaccine study that also came out within the last 3 years. Unfortunately, though, when you take a look at each one of these, there's only one that has been proven to be effective among men who have sex with men and done with men who have sex with men. All the other technologies were technologies that were done with heterosexual populations. And we can't necessarily say that they will be just as effective with men who have sex with men. And actually, when you take a look at the available interventions that we have for men who have sex with men, the efficacy is slightly different, and the list of interventions are also slightly different than the one that I just showed you for heterosexuals. So for treatment as prevention, we still don't know what the efficacy is necessarily for men who have sex with men. If having a high coverage of people who are living with HIV treated, whether or not that's going to reduce new infections among MSM. For NPEP, there's some data from the Explorer study showing a 91% reduction in HIV transmission. For condoms, we have a new study that CDC just released for CROI this year, showing that there's a 70% protective effect associated with condom use for men who have sex with men, though it's really somewhat problematic because that 70% relies upon effective and consistent condom use all the time. And over a 4-year period, what they found in the study is that only 1 in 6 MSM actually had reliable, consistent condom use over a 4-year period. Without that consistent condom use, that protective effect disappears entirely. And then, of course, there's been data on circumcision, and circumcision among populations of heterosexuals with about a 60% reduction in HIV. For men who have sex with men, there's a new Cochrane review that came out, I think, a couple of years ago, where they found a 63% protective effect, but that protective effect was only for men who engaged as tops. We have done several studies that we published looking at circumcision among MSM overall, and you find that overall that there's no protective effect for circumcision for men who have sex with men as compared to other populations. If you are engaging in as a top at one point and then a bottom as another, being a bottom is not going to protect you from HIV. So that's certainly one of the major issues that we have. And then you have such high role versatility in the United States. You find protective effects for serosorting, but it's fairly low for men who have sex with men. And then you have health education and risk reduction interventions, behavioral interventions that can also reduce the likelihood of infection, but unfortunately that's for STI, and we don't have any effective behavioral interventions that reduce HIV among men who have sex with men. Another issue that we have too is really the degree to which men who have sex with men either know about or are using some of these biomedical interventions. So we've had non-occupational post-exposure prophylaxis for quite some time now, as well as guidelines for non-occupational post-exposure prophylaxis. And we've had PrEP now for the last couple of years. But these are data from several studies that have looked at knowledge of PEP and NPEP for men who have sex with men, as well as use over the last several years. And what you can see is a consistent pattern that there are many men who have sex with men who have heard about NPEP or they've heard about PrEP. But when you move over to the usage category, you find that there are precious few men who are lining up for any of these interventions, even though these interventions are extremely effective for our populations. And that's something that I want to discuss a little bit later in our presentation. The other thing that's come up over the last several years is, treatment as prevention and the degree to which we can move through the treatment cascade to reduce viral suppression. And in the U.S. context, we have to look at the treatment cascade in terms of how it relates to men who have sex with men. Here, this is for the entire U.S. About 82% of people are diagnosed, 66% of people living with HIV are linked to care, 37% retained in care, 33% prescribed to ART, and 25% virally suppressed. Looking at the same data, MMP medical monitoring project data for men who have sex with men, you find that the treatment cascade is somewhat different, where men who have sex with men are less likely to be diagnosed with HIV. We also have some differences in terms of those men who have sex with men who are virally suppressed, though perhaps not statistically significant. But this is something else that we need to be taking a good look at as we move forward and trying to figure out how we get to greater rates of viral suppression, ART prescription, retention in care, and linkage to care for men who have sex with men. Now, even though I spoke about the degree to which behavior does not necessarily explain the greater rates of HIV among men who have sex with men, I don't think that we can necessarily discount behavior and the role that behavior is going to play if we try and pull together these interventions in a large scale. And one of the reasons I say that is that, we have data from other countries that show really interesting information. When you take a look at unprotected anal intercourse per act risk of HIV transmission, before antiretroviral therapy and after antiretroviral therapy. There is a study in Australia where they found that the per contact risk for anal intercourse really hasn't substantially changed before antiretroviral therapy was available or afterwards. And mind you, this is in a country where 70% of HIV positive MSM are on antiretroviral therapy, so there's very high coverage. So there's something else that's taking place here as to why we're not necessarily seeing an effect post-antiretroviral therapy availability to really see the per-contact risk of HIV transmission decrease. And some of the reasons are greater rates of STIs, there is not as much adherence as we would like for antiretroviral therapy, and also risk compensation. Dr. Holmes is talking a little bit about some of the behavioral risk compensation that's been taking place ever since antiretroviral therapy has been available. And you could really see some of that risk compensation in some of the data that's been published in meta-analyses. This is a meta-analysis that one of my colleagues at CDC published for HIV-positive MSM across studies. And what you find is that for HIV-positive MSM, that about 30% engage in sex with other HIV-positive MSM, unprotected sex with other HIV-positive MSM. And then they're much less likely to engage in unprotected sex with partners who are unknown status or HIV-negative partners. However, if you combine those categories, you still find that about 26%, about a third, are still engaging in some sort of risk with partners who might be at risk for HIV transmission. The other thing that was interesting in the study is that when you take a look at prior to 2000 and after 2000, you find that there's an increased risk in HIV prevalence, not HIV prevalence, of unprotected anal intercourse among men who have sex with men who are HIV positive. So it increases from 35% to 47%. That's part of the increase that Dr. Holmes is talking about. And likewise, you see that there's a racial component to it, where there's an increase in unprotected anal intercourse among white MSM, but not necessarily for MSM of color. And this is something that you see over and over again, is that MSM of color do not report engaging in as high rates of unprotected anal intercourse as compared with white MSM. Now, it's not just HIV-positive MSM where we're seeing rates of sexual risk that are increasing. You're seeing it among all MSM. And this is another meta-analysis from my same colleagues, Nicole Krapaz at CDC, where she was just interested in the degree to which how beliefs that antiretroviral therapy reduces the likelihood of HIV transmission is associated with a greater likelihood of engaging in unprotected anal intercourse. And this is just the forest plot of all the studies that have been done and the odds ratio where they found that there's a greater likelihood of engaging in unprotected anal intercourse if you believe that antiretroviral therapy reduces the risk of HIV transmission for MSM. And then, of course, the other thing that's happening concurrently, and we're seeing it in Seattle and across nationally, is serosorting. Serosorting is a practice where you seek a partner of the same HIV status, generally men who are HIV negative, looking for men who are HIV negative. If you're HIV positive, looking for men who are HIV positive. And you're looking to have unprotected anal intercourse and believe that this is a way that you can prevent HIV transmission. Now, there have been several studies that have looked at the degree to which serosorting actually prevents HIV transmission. There was one from the EXPLORE study where they did find a protective effect associated with serosorting. However, they also found that over the course of the study for the men who are enrolled, that there were about several new infections, about 259 new infections, which really could have been contributed to serosorting. So men who believed that their partners were HIV negative, that was actually a risk factor for seroconverting within that study. You also find similar things here in Seattle. There's a fantastic paper that Matt Golden had at CROI a year ago, where they're looking at serosorting among HIV-positive MSM and found that it increased from 28% to 38% between 2002 and 2010 among MSM in Seattle. And they found that that increase in serosorting was correlated with a rise in local syphilis here in Seattle, exactly what Dr. Holmes is talking about as well, that a lot of the serosorting is taking place among HIV-positive MSM, and it's responsible for the rise that we're seeing in syphilis. You're also seeing it, unfortunately, reflected in some of the ads that people have up to hook up with partners. This is an ad from Craigslist that I pulled right on, actually on the plane on the way here. I got some looks from the people who are next to me while I was pulling it up. It's definitely interesting. But what you can see is that, this is a young Latino man who wants to engage in bareback sex, BB, bareback sex, unprotected sex, who's looking to serosort. He's HIV negative. He's looking for an HIV negative partner. And this is something that you see not just in Seattle, you see it all over the United States of men who are engaging in these behaviors thinking that it's going to reduce their risk of HIV transmission. This is another way of looking at the data that King Holmes just took a look at and discussed. And this is at the national level at the percentage of syphilis among men who have sex with men compared to heterosexuals between 2000 and 2009. And just as he's explained, there's been a rapid increase in the percentage of syphilis cases among men who have sex with men between 2000 and 2009, reflecting that increase in behavior, high risk behavior that I discussed since antiretroviral therapy. In 2000, only 4% of syphilis cases were among MSM. By 2009, 63% of cases were among men who have sex with men. Now, bringing all of this home, why it's so concerning to look at the issue of risk behavior is because risk behavior also interplays with biology in other ways. This is a study that was published last year where they were looking at the prevalence of seminal HIV shedding for HIV-positive MSM who are on stable antiretroviral therapy. And for people who are on stable antiretroviral therapy, we assume that they're non-infectious, but that's not necessarily the case. Of the 101 MSM in the study, 30% had detectable HIV DNA and or RNA in their semen, and about 20% had detectable HIV in their blood plasma. Of the 83 MSM with undetectable blood plasma in the study, 25% had detectable HIV in their semen, and they were also 11 times had greater odds of having an STI. So there's probably breakthrough HIV because of an STI. And then when you take a look at behavior, again, why we can't say that behavior is not really a component when we take a look at these strategies. These men with undetectable blood plasma but had HIV breakthroughs were 5.5 times more likely to engage in insertive anal intercourse with a partner recently. So there's certainly some transmission possibilities that are taking place there. In terms of these new technologies as well and how we deal with HIV prevention, there's quite a few things that we need to take a look at with racial and ethnic disparities among men who have sex with men. And as I was talking about the rise in syphilis among men who have sex with men, unfortunately, there's also a racial component that's associated with it as well. These are amongst some of the first surveillance data that we have from CDC. Looking at STD surveillance among men who have sex with men, it's from a study from a colleague, John Su, that he published 2 years ago, where we looked at surveillance in 27 states from 2005 to 2008, and there was an absolute increase in rates of syphilis among black MSM as well as Latino MSM compared to white MSM, and that we also found greater HIV syphilis co-infection taking place among black MSM and particularly young black MSM. I also published a meta-analysis last year where we were taking a look at all of the studies that have been published to date to see differences in STI as well as other risk behaviors and outcomes from black men who have sex with men compared to other men who have sex with men. And we find that it's not just syphilis that we found that black MSM were more likely to have compared to other MSM. We found that black MSM were more likely to have any lifetime diagnosis of an STI, current diagnosis of an STI, more likely to have syphilis, as I'd mentioned, herpes simplex. We're also found greater rates of chlamydia infection across studies for black MSM compared with other MSM. And black MSM were also more likely to have any type of urethral STI. Interestingly, across studies you find that black MSM are less likely to have a pharyngeal STI, and that's actually something that's really correlated with the behavior because you find across studies that black MSM are less likely to engage in oral sex as compared to white MSM or MSM of other races and ethnicities, and you see that reflected in the biological outcome that you see here. Now, some of the reasons why we're seeing these higher rates among black MSM as well as other MSM of color is really marginalization. It's not necessarily the risk behavior that's taking place. These are data from the National HIV Behavioral Surveillance Study, and just to give you an idea of what we mean by marginalization, you find in this data set, you also actually find it among other populations, that not being a high school graduate, having a lower income, are both associated with a greater prevalence of HIV. So HIV is really a disease among marginalized populations in our society, not people who are necessarily college graduates or make over a certain amount of money, though they are also as likely to get infected with HIV. And then these are data from the HBTN 061, fantastic study. It's the first prospective study, large study for black men who have sex with men, which really brings home some of these structural issues that I was talking about in terms of income, unemployment, et cetera, where they found these whopping odds ratios that were associated with new infections for black MSM, associated with being unemployed, not having stable housing, having a low income, et cetera. So again, these measures of marginalization, which are also contributing to these disparities that we see by race and ethnicity. Another one of the structural issues that we see that also contributes to the disparities by race and ethnicity is insurance access by race. You find that white Americans are more likely to have access to health insurance across the country as compared to blacks or in particular Latinos. You find in survey after survey that Latinos are far more likely to be uninsured compared to all other populations in the United States. And unfortunately, this bears itself out as well in terms of what we're doing in terms of HIV care and prevention. This is a paper that was published last year where they were looking at CD4 count among immigrants versus US-born populations who are living with HIV. And they found that among immigrants, that they were more likely to have a lower CD4 or an opportunistic infection compared to US-born individuals. They were more likely to have a higher CD4 or opportunistic infection if they were monolingual. And then they also found the prevalence of OIs was much higher among that population as compared to individuals who were US born. And then in their multivariate analysis, independently, they found that just being an immigrant was associated with a greater likelihood of having an opportunistic infection among this population. Now, I would probably gander that this is not just for Latino populations, that I'm sure that for other populations, immigrants from endemic countries, from HIV, from the Caribbean, as well as Africa, that we'd probably find a lot of the same associations. And I would also gander that you might even find some of these associations among Asian and Pacific Islander MSM between US-born and those who are not in terms of access to health care and being able to control their disease status. You also find, unfortunately, some of these differences by race and ethnicity also for clinical care for black men who have sex with men compared to other men who have sex with men. Now, this is a forest plot that my colleagues and I put together. Here is all of the things that we know are associated with a greater likelihood of HIV infection across studies. And we basically plotted out what the odds ratios are, the combined odds ratios across studies comparing black men who have sex with men compared to other MSM. On this side, it means it's a greater likelihood of black MSM compared with other MSM. On this side, it's a lower likelihood of black MSM compared with other MSM. And anything, of course, that crosses 1 was not statistically significant between both racial groups. And the thing that's really interesting is that you find, exactly as I'd mentioned beforehand, that across studies, black men who have sex with men engage in less types of risk behavior, number of sex partners, drug use before sex, amphetamines, amyl nitrites, et cetera. But we're still about 3 times more likely to be HIV positive compared with other men who have sex with men. But the thing that was very interesting was to find that the plurality of the disparities that we see among black men who have sex with men compared with other men who have sex with men happen to deal with clinical care and clinical care outcomes. So that was the thing that was really interesting for us. It was also interesting to see that the greatest outcome that we know that's associated with a lot higher likelihood of HIV infection was sort of the assortative mixing that's taking place among black men who have sex with men. Across studies, we are nearly 12 times more likely to have a black partner as compared to other individuals having a black partner. And I'll go into that a little bit later. And this is just another way of looking at some of the disparities that we found in clinical care and looking at it in terms of the treatment cascade. So we found a higher rate of undiagnosed HIV infection among black MSM compared with other MSM. We also found that black MSM were more likely to be diagnosed with HIV compared with other MSM across studies. But then see how the ORs flip once we get into clinical care indicators. Black MSM are less likely to have access to antiretroviral therapy. They're less likely to start an ART initiation at a higher CD4. They're less likely to have as many healthcare visits or to adhere to antiretroviral therapy, and less likely to be virally suppressed. We also found that HIV-positive black MSM are more likely to have a lower income compared to other HIV-positive men, which I'm sure is some of the reasons why we're seeing some of the lower rates of viral suppression that we see here. We also find that black MSM are less likely to have health insurance compared with other MSM once they're HIV positive, and we also find that for HIV negative black MSM. Now, one thing that was interesting is to take a look at HIV suppression. We know that black MSM are less likely to be virally suppressed compared to white MSM. You find the same thing for Latino MSM. There's a study that colleagues of mine at CDC just published about 2 weeks ago, where they're looking at differences in viral suppression between black MSM, Latino MSM, and white MSM. And they found that you need to have an additional 40,000 black MSM diagnosed, an additional 17,000 Latino MSM diagnosed, and to be on treatment to raise viral suppression levels that would get rid of the disparities that we see. So that's one of the major issues that we have here. We also have issues in terms of physicians in diagnosing HIV. The problem is that if we really need to get to the point of reducing those disparities, we have to have physicians who diagnose people living with HIV. And this is a paper that we have from Brothers Hermanos, a large study of black MSM, where we found that black MSM were more likely to have health insurance and to have disclosed their sexuality to their partner. These are black MSM who are undiagnosed and didn't realize that they were HIV positive. Yet they were 94% less likely to have more than 3 lifetime HIV tests. So these are really the low-hanging fruit, no pun intended. These are men who are in care, they are undiagnosed, and they're not being diagnosed. They're less likely to have an HIV test. And unfortunately, it has ramifications in terms of HIV transmission, with many of these men engaging in higher rates of risk behavior with partners who are potentially HIV negative or uninfected. The other issues that we have to deal with are beliefs surrounding antiretroviral therapy, particularly in minority communities. We know that minority communities are less likely to believe healthcare systems compared to other communities. These are data from Angela Hutchinson in CDC, where we found higher rates of conspiracy beliefs among black MSM and Latino MSM compared with white MSM across studies. And we know that these higher rates of conspiracy beliefs are also associated with not getting tested for HIV. It's associated with not taking HIV medication, and it's also associated with missing routine clinical care visits. So that's something else that we have to deal with in terms of some of these racial disparities among men who have sex with men. One other issue that we have for the racial disparities among men who have sex with men is the degree to which, as I had mentioned before, viral suppression is acting in some of the transmission that we're seeing for black and Latino men who have sex with men. We know that black MSM are less likely to be virally suppressed compared with white MSM or to be aware of their HIV infection. Latino MSM are also less likely to be aware of their HIV infection compared with white MSM. Find the same thing with viral suppression. The interesting thing here, though, is that you find similar rates of risk behavior among those individuals with unsuppressed viral load. But if you have greater rates of people who do not know their HIV status and greater rates of people who are not virally suppressed in MSM of color communities, even if they're engaging in the same rates of risk behavior or less risk behavior, they're still more likely to transmit to partners within those communities. And that's certainly something that we see for black MSM who say that they engage in seropositioning or serosorting. Across studies, they're more likely to become infected with HIV compared with other MSM. So they're engaging in behaviors to protect themselves, but because there's so much HIV in our communities, they're still more likely to seroconvert. There's also a fantastic paper that Patrick Sullivan just published this year. It's really one of my favorite papers, I have to admit, which takes a look at this whole issue of behavioral interventions or behavioral risks in STIs among MSM by race and ethnicities. And basically what they found is that black MSM in their prospective study were less likely to have a suppressed viral load, which is something that I'd already showed from the meta-analysis. But they also did something that was a step further. They were looking at transmission possibilities by the number of partners, unprotected anal intercourse partners. And they found that black MSM who had 2 unprotected anal intercourse partners had a 40% likelihood of HIV transmission or coming into contact with an HIV transmission partner, whereas white MSM only had a 20% likelihood of coming into contact with an HIV transmission partner. And what I thought was really telling here, I just had to go ahead and put in the box that they put in the study, was that for black MSM, even a relatively low number of UAI partners, 3 partners, leads to a 50% chance of being exposed exposed to at least one partner with the risk of transmitting HIV, because we have so many individuals who are undiagnosed in our community. And for Black MSM with 5 unprotected anal intercourse partners, the estimated probability of being exposed to HIV by one partner was 60%. And if you reduce the number of UAI partners by 1/3 among Black MSM, the estimated probability of exposure to HIV by at least one partner was still 50%. So even though we can have effective risk reduction interventions, an effective risk reduction intervention is not going to do that much to reduce the probability of having a partner who has a possibility of HIV transmission for Black MSM. Whereas when you take a look among white MSM to have a 50% probability of exposure to at least one partner, they had to have at least 7 unprotected anal intercourse partners. So for Black MSM, it was only 3. For white MSM, it was 7. So what are some of the opportunities that we have in moving forward with HIV prevention among MSM? One thing is that the enemy doesn't have to be the perfect of the good. This is a modeling paper that colleagues of mine from CDC published based upon an MSM epidemic in New York City. And you can find that if we do nothing, of course, the epidemic remains the same, the number of new infections. Whereas over a 20-year period, if you just do intermediate HIV testing, you see a reduction in the number of new infections. If you do optimal HIV testing, if we're able to test as many MSM as possible and to get them diagnosed, you see a further reduction. You also find the same thing with combination prevention. For those combination prevention packages that were intermediate in terms of we're not getting adequate coverage, you're still going to see a reduction in HIV incidence over a 20-year period, with even a greater reduction with optimal combinations. So the enemy doesn't have to be the perfect of the good, at least in modeling studies, for us to get to some sort of reductions among men who have sex with men. The other thing that's an opportunity is that we see increasing HIV awareness among men who have sex with men. These are data that were published during CROI this year. And remember how I was telling you that we have high rates of undiagnosed HIV infection among men who have sex with men compared to some other populations. The good thing is that we're seeing that there's greater numbers of men who have sex with men who are being diagnosed with HIV and are aware that they're HIV positive. So between 2008 and 2011, you saw an increase in the number of men who have sex with men who are HIV positive and aware of their status. And more importantly, for those young MSM where we see the epidemic growing, you also see a substantial increase in awareness of HIV positive status among young MSM. This is important, of course, because we know that people with undiagnosed HIV are responsible for new transmissions, most of the new transmissions that take place each year. Other opportunities is that we know that viral suppression actually reduces rectal shedding, and that this takes place even in the presence of sexually transmitted diseases. So this is something that's particularly important. We have a greater likelihood of HIV infection through anal sex, but if a man is virally suppressed, then he is less likely to shed HIV. And if he's having sex with a partner who is HIV negative, also less likely to transmit to that partner. We also see some of this in practice, too, with exciting new data from San Francisco, where they find perhaps a trend towards reducing HIV incidence among men who have sex with men because of treatment as prevention. What they found in their NHBS data between 2004 and 2011 is they found actually an increase in the number of men who are getting tested for HIV. They found a decrease in the number of men with undiagnosed HIV infection, and they were finding a trend towards a reduction in HIV incidence in San Francisco over that period of time. And all of this is happening in the context of still men having multiple sexual partners over that period of time, about 70, 78%, and also in the context of STIs still taking place within that period of time. So treatment as prevention is something that is possible. It's something that might be able to reduce new infections among men who have sex with men, with heavy on the might, because San Francisco is not reflective of the rest of the United States, and there's an awful lot of things that are taking place in San Francisco that necessarily can't take place in the rest of the U.S. The other opportunities that we have is we really need to take a look at other comorbidities that are associated with HIV, as well as other sexual health issues and other issues that are associated with HIV. We know that men who have sex with men who are prone to various syndemics, if they're engaging in polydrug use, depression, childhood sexual abuse history, partner violence, that depending upon how many of those outcomes that they have, are more likely to be HIV positive. And why I say that is that it's important to take a look at some of these syndemics and other issues when we take a look at the demographic factors that are associated with noncompliance. One of the things that really drives me crazy is when you take a look at the PrEP studies and other studies that people keep harping on adherence and what's wrong with these communities because they're just not adhering to these medications. And I'm not sure if that's really the proper question. The communities that we see that people say have less than optimal adherence are adolescents, substance users, communities of colors, low-income individuals, those individuals who are depressed or mentally ill. And you see that for HIV testing, attending to clinical visits, or adherence to medication. I really think that the relevant question is, how is HIV prevention and care interventions relevant to these people's lives? And are we pulling together interventions that are relevant to these people's lives? And more importantly, how do these syndemics affect healthcare access? And how is it related to noncompliance among these communities? And why I think that that's important is that it's very rare for us to actually ask communities what types of interventions they need, what types of interventions that they want. And this is a study that came from Australia several years ago where they were taking a look at pulling together their syphilis program. Just like here in the United States, they have skyrocketing syphilis rates among men who have sex with men. And they just asked men who have sex with men, would you be willing to change your risk behavior to reduce transmission risk for syphilis? And what you find is that very few men who have sex with men said that they are willing to change their behavior to reduce their risk for syphilis, whether it's to change their behavior for their own transmission risk or to reduce the community's transmission risk. And basically what the author said was that diminishing sexual pleasure beyond what they had already done to minimize HIV transmission was not warranted in their view. And ultimately they decided that behavioral interventions were not going to be helpful in reducing syphilis for the syphilis elimination plan among men who have sex with men in Australia. I think we need to do a better job in the United States as well of listening to men who have sex with men in terms of the interventions that we put forward. I'm going to skip through this slide really quickly. The other thing that we need to take a look at as well is the types of interventions that we're funding and whether or not we're actually prioritizing men who have sex with men. As I'd mentioned beforehand, most of the new infections that are taking place are among young MSM and particularly young MSM of color. There was a review that was done to take a look at all of the interventions that have been published between 1991 and 2010 for youth. And what they found, unsurprisingly, is over that time period, surprisingly few interventions for young MSM, whereas quite a few interventions for young heterosexuals. Unfortunately, young heterosexuals in the United States is not where the epidemic is. The epidemic is among young MSM. So there's another structural issue, some sort of bias or something that's taking place, even with the research that's getting done. We also see it at the federal level in terms of funding, and here I'm only focusing on NIH, but you see it for CDC and you see it for others, where even though men who have sex with men comprise 2/3 of the new infections that take place each year, they also comprise the least of the funding for HIV prevention research, for HIV care, as well as for other HIV programs across the federal level. Another thing that we need to do as well is we just can't focus on what's taking place at the federal level. We need to also include communities and have community re-engaged in HIV. It's wonderful to see the GLBT community engaged around marriage and marriage rights and many other issues. What's a shame, though, being at the White House, is to see how few times you see HIV mentioned at all in the press with the press clips that we get each day. And then beyond that, how little times it's mentioned from GLBT populations. Growing up in New York City at the height of the epidemic, I couldn't go a day without press clips about what's taking place in my community in HIV. Whereas now, we are basically silent in terms of talking about HIV in MSM communities. I just wanted to highlight here some really fantastic new campaigns for reducing stigma from some MSM organizations. It's much better than what we see at the federal level because, of course, anything with federal dollars, you can't be as explicit as you would like. But, people who are using this campaign saying clean, you be too, dirty is for laundry, it's not for your HIV status. It's really getting at a lot of these things that we see for sexual hookups where people are saying that you need to be HIV negative or clean. I also think, too, that we need to take a look in terms of opportunities of the degree to which our epidemic is similar to other epidemics internationally. So, for instance, here, this is from a meta-analysis where we looked at studies of black MSM versus other MSM in Canada, the US, and in the UK. And you find similar things in terms of the epidemic for the United States as well as the UK. Black MSM here are just as likely to engage in unprotected anal intercourse as other MSM. They're just as likely to engage in serodiscordant intercourse as other MSM, but we're still more likely to be HIV positive. You find the same thing in UK and the US. You also find that black MSM are more likely to have an STI in the UK and the US. More importantly, when you take a look at antiretroviral therapy and access to antiretroviral therapy, once black MSM are diagnosed in the US or the UK, they're less likely to be on antiretroviral therapy compared with other MSM. So we can learn from other contexts and see some of the similarities that are taking place in MSM epidemics across the world. So in terms of where do we go from here and some of the things that I'm hoping that we discuss today, I'm not going to go through the laundry list of some of the things that I hope to hear about in terms of epidemiological research, implementation research, program work, or basic science research. But I do want to highlight a couple of things. One thing that we definitely need is we need more research on improving the measurement of structural level factors and the degree to which they're associated with HIV transmission in the United States. We know that structural level factors, that there may be an association, but we also know that the association is not necessarily linear. When you take a look at the Netherlands is perhaps one of the most accepting places for men who have sex with men across the world, but you still have a raging epidemic in terms of new infections there as well. So having gay marriage is not necessarily going to reduce magically the number of new infections in the United States. I'd like to see more in terms of healthcare access and treatment adherence, more research for that for foreign-born MSM of color. I haven't seen as much research on that, as well as for trans populations, which I didn't discuss today, though there's a meta-analysis showing that in the United States that upwards of 20% of trans women who are HIV positive, and there's certainly quite a bit that we need to do there. Obviously, in terms of implementation research, as I'd mentioned before, there's lessons learned from MSM epidemics from other countries where they're finding that treatment as prevention is not necessarily working, and trying to figure out, well, how treatment as prevention might be applicable to the United States in those contexts where they're seeing that it's not necessarily working. We need more implementation research in terms of network interventions, exactly what Martina Morris and others have been asking for many years. We do have some interesting interventions for networks, but we haven't really moved beyond to things that are more effective or taking a look at the changing landscape of risk for MSM across the United States. Obviously, we need to re-engage MSM communities, and in terms of basic science research, we really need to figure out how we can do different dosing for antiretroviral therapy for men who are HIV positive or HIV negative. It's clear that dosing on a daily basis might not be optimal for adherence, but if we can move to weekly, monthly, or even yearly dosing for antiretroviral therapy, that might increase adherence. We also ultimately need an effective anal microbicide for men who have sex with men. That's something that would be incredible to add to the armamentarium of things that are already available. And with that, look forward to any questions you have, and thank you for your time.